Mr. Chairman, Professor Dr. APM Surabujjawan, our teacher, chief guest, Professor Dr. Rafiq Ahmed, dear panelists, moderators, and learned participants. And good evening, everybody. I welcome all of you to my talk, Satisfactory Short-Term Responder for CRT-D device implant on non-LBBB patient, a case report. A 65 years old man with history of triple basal coronary artery disease, CABG surgery on 2020, diabetic, hypertensive, presented to us with the complaints of recurrent syncope with vomiting for 2 days. Admission ECG showed extreme bradycardia, bifascicular block, first degree AV block, white QRS complex with duration 165 milliseconds. Echo revealed dilated LV regional wall motion abnormality with dysynchrony, and LV ejection fraction was 31%. TPM inserted in RV. There was no evidence of reinfarction. He was subjected to CRT-D implant as a non-LBBB patient. Admission ECG showed white QRS complex and bifascicular block. And this ECG also showed first degree AV block. This is the freeze frame image of triple chamber pacemaker with dual chamber ICD. Pre-implant ECG duration was 165, post-implant QRS duration came down to 126 milliseconds. Parameters of CRT response. In this case, patient showed remarkable clinical improvement and narrowing of QRS duration about 40 milliseconds. And there was RBB pattern and B1, and there was axis change, left, right superior axis. Programming. We programmed the ICD as a primary prevention 2 zone, and for bivalent pacemaker, we used multipolar coronary sinus lead. During implant, our QLB distance was 93 milliseconds and RVLB distance was 113 milliseconds. We use multi-point pacing. In this case, ICD implanted as the patient had ejection fraction less than 35%. Our goal of treatment was only appropriate therapy by reducing the shock therapy by using non-committed shock, ATP, SBT discrimination, filters for T-wave and noise, ATP for fast BT, strategic programming for detection time and rate, delayed therapy. Inappropriate and appropriate therapy. Inappropriate therapy means therapy for anything other than BT and BF rhythm, and appropriate therapy delivered for BT BF. This is the pie diagram showing the percentage of appropriate and inappropriate shock. Reducing the inappropriate and unnecessary shock, we should ensure sensitive and specific discrimination of SBT, address T-wave oversensing, electromagnetic interference, detect lead failure, appropriate programming for non-sustained BT, and discrimination overrides. Lead failure. Lead problems may prevent the device from correct differentiation, discriminating from BT from SBT. T-wave oversensing and electromagnetic interference also causes inappropriate shock. This is a case of BT patient with ICD implanted. Sometimes ICD implanted patient may need radiofrequency ablation, and sometimes ATP can exaggerate the BT. Particularly this case, this patient was admitted, another patient admitted our hospital with recurrent BT for 2 weeks. We escalated all therapy but failed. Ultimately, she underwent for radiofrequency ablation for relief of BT, and he relieved BT. Now BT storm and solo BT. For solo BT, management, we need adjust drugs, reprogramming, and radiofrequency ablation. VT storm sometimes needs radiofrequency ablation and other escalated therapy. Now, inappropriate shock may be minimized by addressing poor discrimination of BT due to misclassification of SBT, lead problems, TF oversensing, and EMI, turning of discriminator overdrives. Particular, our case belongs to the category of for biventricular pacemaker. This case belongs to class 2A with level of evidence B, as our case was non-LBB with QRS duration more than 150 milliseconds. The magnitude of response, more wider the QRS complex, more is the better response. Benefit of CRT, lot of benefit we can achieve after proper implantation of CRT. In case of normal conduction, impulse takes time about 40 seconds from the interventricular septum to lateral wall, 40 milliseconds. In case of LBB, it increases 100 milliseconds more to reach the lateral wall from the ventricular septum. Potential reasons for suboptimal CRT response, it may be due to suboptimal AV timing, various arrhythmias, suboptimal lead position, and biventricular pacing less than 90% and others. This is the merit credit for CRT response. This is the survival benefit of CRT implanted. LBB category patient shows more survival benefit than non-LBB category. Activation pattern with conduction abnormality in patient of LBB, RBB, and left ventricular hemiblock. This is used to select the delayed point for maximum site of lead placement. The percentage of responders, super responders, and non-responders. Methods to optimize the CRT response: optimal lead position and type of lead, avoid apical placement, quadrupolar lead is best, close the best vector for response, QLB and RV-LV interval. Optimal AV and VV delays can be optimized by quick op, AV, SYNC-AV plus, optimal uniform resynchronization by multi-point pacing system. CRT and VV optimization during follow-up visit 3 to 6 months. Method echo-based, ECG-based, device-based, ECG-based is best. Now, during implant, we determine the QLB interval. More the QLB interval, more better will be the response. Our cases, the QLB interval was more than about 93 milliseconds. Multipoint pacing. Multipoint pacing, two-side LV stimulation, it gives capture a large area, improve pattern of depolarization, repolarization, improve hemodynamics, improve resynchronization, and improve CRT response. In heart failure and increased LV size patient, it gives better response. Now, the SYNC-AV CRT, it gives fusion pacing. It ameliorates electrical and mechanical synchrony. It gives dynamical adjust timing AV delay based on intrinsic patient rhythm. Drives fusion bit with intrinsic rhythm. New parameters SYNC-AV and delta. It gives permanently programmed AV delays. If we on the SYNC-AV, there will be less chance of atrial tachycardia and atrial fibrillation. Adaptive CRT. It gives dynamic physiological pacing, adjusting CRT parameter automatically with change in patient activity levels and conduction status. It reduces death about 30%. Adaptive CRT. Normally, the impulse comes from the atrial level through the his bundle, goes to the ventricles, and there occurs parallel activation of the both ventricle from apex to base. Here I have shown normal activation, and in case of LBB, there is delayed activation of the left ventricle. In case of biventricular pacemaker, there is early activation of the left ventricle. This special loop for biventricular LV and RV pacing. In case of RV pacing, there will be no benefit. In case of biventricular pacing, if we pace properly, then there will be increased DPDT, increased cardiac output, increased left ventricular ejection fraction, and increased pulse pressure. CRT is an established therapy for selected patient with heart failure due to reduced LVEF. If this CRT fails, then what we should do? We should go for his bundle pacing or bundle balance correction. Who will benefit from his bundle pacing? Complete heart block patient, decreased LV function not fulfilling criteria for CRT, failed CRT, decreased LV function not LBB with increased PR interval, AV nodal dysfunction or risk of AV nodal disease. If this CRT and his bundle pacing fail, then we should go for bridging for mechanical circulatory support device for transplantation. Now, heart transplantation technique. I have just tried to show here how the recipient heart and donor heart are placed together. Now, see a patient of cardiac transplantation. It is easy to pass away, but I want to stay around when it happens. Thanks all for patient sharing.
Thank you, Dr. Muqaddus Hassan Sadi, for a nice case presentation. Now the floor is open for discussion. Any panelists want to say something?
Dr. Sadi, can you show the pre-implant ECG again, please?
Sure. Pre-implant ECG. Yes, this is the pre-implant ECG.
No, next slide, next slide.
Next.
No.
Yes.
This one.
This is pre-implant, post-implant. Pre-implant.
You go to the other one ECG, other one ECG that you have shown just now. Other one. Go. Not that one. Go backward. Not that one. Other one also. Okay. This was the pre-implant. Other one. There is other one ECG.
No. This one and this one.
No. This is there is another one.
No, yes.
Please stay here.
Yeah.
How is the QRS duration here, Sadi bhai?
QRS duration was 165 milliseconds.
এর আগেরটাই সাদি ভাই না এসসিজি is it sinus brady or 2:1 AV block?
This one.
Sometimes 2:1 AV block also.
Yes.
Sometimes 2:1 AV block PR interval.
Rupik sir and Sadi sir, আমার একটা কোশ্চেন আছে regarding PR interval for poor responder or good responder. Rupik sir, Atash sir, অথবা Mohsin bhai, any idea or any conception or any opinion regarding prolonged PR interval patient do well with CRT and short PR interval less chance of responder?
This ECG that I have here, with this ECG, we will not put BIV in because it's mainly right bundle.
Yes, sir.
And left anterior fascicular block, but if you look at 2-3 AVF, the initial R is not very wide and the PR is short. If on the other hand, this PR was long, I will be a little bit more inclined. However, if you go to the next ECG.
Next one, please, Sadi bhai.
This is the reason this patient has syncope.
Yes, this one.
This is actually Mobius type 2 second degree AV block.
Yes, sir.
And so
I guess
in this case, if I put a pace, he's going to pace most of the time, and that makes the indication for ICD by VICD valid.
Sir, can I make a comment, sir?
Yes.
Sir, the patient has got the loss of consciousness with vomiting. We have given a history of that is the.
This is a 2:1 in this one ECG.
The vomiting, this binodal block.
Oh, well, I can't explain the vomiting, but you have to understand if somebody went into asystole and started seizing, the vomiting can be a secondary. The question is, if you take careful history, which came first? If somebody started vomiting and then they passed out, that's one way. Other way, somebody passed out and then woke up and vomited, that's a different story. So I think that's where history comes in. I think this patient went into intermittent complete heart block with asystole that made syncope.
Yes,
and then this ECG we saw 2:1 heart block. So ideally, we try to avoid BiV in right bundle because it is difficult to, but in this case, it was a good decision to put a BiV ICD in. Thank you.
So what about the PR interval?
PR interval is about 200.
Question.
230 milliseconds. In this ECG, it is 230 milliseconds.
Ropik sir কাছে আমি কোশ্চেন করছিলাম PR interval, is there any role of good responding with the CRT?
Yes, the PR interval, we play with it. I mean, we start with the standard programming. But we
initial ECG, sir. Initial ECG. Suppose a patient with RBB or LBB with short PR. Short PR means 120, 130. Other one has got PR with 220 milliseconds. So who will respond better?
Okay,
because some of the big electrophysiologists I have seen, like Angelo Maurizio, he came in our institute. Always he emphasized what is the PR interval. So several ECG we have shown, and first thing he asked what is the PR interval. I think there is something that is not yet in the protocol, yet not in the guideline. PR interval have got some role for good CRT responder.
Yeah, his question absolutely correct. With the right bundle, if the PR interval is normal, we will not even consider BiV. Because with the right bundle, the data is very confusing. So the thing is that with right bundle, if the PR is prolonged, there is some benefit. With left bundle, it doesn't matter. Irrespective of PR interval, they do benefit. One of the things that happens, if the PR interval is short with left bundle, you can program LV only pace with Medtronic pacer. And the other thing that Sadi mentioned, multipoint pacing is an excellent idea, but please remember you are going to waste more battery on that.
Yes.
So unless it is absolutely necessary, we do not program multipoint pacing because these devices are very expensive and you can quickly deplete the battery.
Yes, thank you, sir.
I want to add something. In Ashok's question, if the PR interval is more than 220, the Medtronic adaptive CRT is not working. So if you want to sense the atrial sense and LV pace, so if the PR interval is less than 220, so it will be work. So this is the importance of PR interval in Medtronic by the adaptive CRT.
Sir, PR interval is not the criteria in the guidelines are also. So
no guideline. I'm telling about the adaptive CRT is working when the PR interval is less than 220.
Yes, sir.
Professor Moshin, আমরা তো পিয়ার ইন্টারভেলটাকে স্ট্যান্ডার্ডাইজেশন করতে পারি আমরা, তাই না? এটা তো আমাদের ইয়েতে প্রোগ্রামিং করতে পারি আমরা। পিয়ার ইন্টারভেল ইজ দেয়ার ইম্পর্টেন্ট ইস্যু হিয়ার।
না ওটা তো পিয়ার ইন্টারভেল প্রোগ্রাম তো আমাদের শর্ট না করলে তো আপনার হবে না, আপনার কি বলে বাইবি পেসিংই তো হবে না। পেসিংই হবে না, কিন্তু অ্যাডাপটিভ সিআরটি যদি ওয়ার্ক করে অনলি আপনার অ্যাট্রিয়াল সিনক্রোনাইজড এলভি পেসিং ইন সিনক্রোনাইজড উইথ আরভি। RV will not pace based on the LV. In that case, PR interval should not be, it should be less than 220. If more than 220, it will be BiV. It will be on adaptive CRT.
যখন অ্যাডাপটিভ দেওয়া হবে তখন পিআর ইন্টারভেলটাকে আপনি চেঞ্জ করতে পারবেন না, এটা হচ্ছে ইম্পর্টেন্ট ইস্যু। যখন অ্যাডাপটিভ মোডে দেওয়া হবে তখন এ সেন্স করবে, মানে অ্যাট্রিয়া সেন্স করবে, দেন থ্রু দ্য নর্মাল ওয়ে right bundle দিয়ে এটা পেস করবে, then LV pacing will be start.
কিন্তু if the peer interval is more than 220, adaptive will not work.
Yes, adaptive will not be working. Yes. Adaptive cannot be on.
Dr. Sadi.
Atas, sir.
Hello.
Any comment regarding this one? This one, is it clear, sir?
Yeah, I want to know from Dr. Sadi, excellent and case selection, particularly discussed by Ropik sir, that is the first and the second decision, very difficult decision. And you took the right decision, you claimed that the patient had got a good responder. So what is the functional status change and echo changes at 6 weeks? Do you have that data, Sadi, at 6 weeks?
We have implanted the patient 2 months ago. Next time when patient return back, then we will assess the further.
So it is a short term. I will say.
So by this time, patient symptomatically improve.
Yeah? I will let you know, and we will publish to everybody. My request. I have written in chat also. All the cases we have discussed today, please write it down for our journal. And send it to
patient may improve because of underlying correction of the heart block. This may be the reason. I think.
Anyhow, this patient definitively need dual chamber pacing. So I think there is no harm to put another lead in the LV.
No harm. But
Ashok, his ejection fraction is already 30.
30, yes, sir.
Already 30. You cannot pace RV.
Yes, of course. Thank you, sir.
Poppy, other panelist.
Thank you. Poppy is having a network problem, and Dr. Alia left for attending an emergency hospital in the emergency room in CMX. So we missed this person. Dr. Asif Tushak, you are keeping silent. You say something.
Jamil bhai.
All the younger should come forward.
Yeah. Asif Jamal Tushar. Are you there? Tushar?
Jamil bhai, আমি একটা স্যার।
Yes, no sir, please.
Tushar.
স্যার আমার একটা পার্সোনাল ইস্যু স্যার, আমি কি এখানে একটু ডিসকাস করতে পারি স্যার?
করো।
Personal কিন্তু EP related.
না EP not EP related, CRT related, যে রফিক স্যার আমি পাবো না। বিশেষ করে মেইন ইস্যু যে রফিক স্যার। স্যার আমার একটা পেশেন্ট 9 মাস পরে স্যার CRT লিড ডিসলজমেন্ট নিয়ে আসছে স্যার। এখন আমি কি করতে পারি? কি ধরনের লিড দিব স্যার? LB লিডটাকে আমাকে আবার রিপ্লেস করতে হবে 9 মাস পরে।
So I mean the question is LB, so one problem with the vein is patent, you can go for an active fixation lead. But if you go for the active fixation, please make sure that when you advance the lead, don't go too far out. Because if you go too far out, the lead body will rotate, but the tip will not rotate. And the active fixation will not work. So that is the trick to the active fixation. You must make sure that the tip is rotating, but you cannot see the tip rotating. That's, I think, Medtronic active fixation is a good option depending on the vein size.
Sadhbhai, can you please stop sharing your screen? Sadhbhai, please stop. Oh, thank you. So, anybody else wants to put any comments? Abu Salim?
Sir, thank you. I want to know one point about the last case. What about the coronary angiogram of that patient? To Sadi sir, did you go for the coronary angiogram status of this patient?
This was a case of triple vessel disease and underwent CVC surgery 2020. In this setting, we investigated for reinfarction. There was no evidence of reinfarction, so we have not searched for coronary artery.
So before bypass, what was the ejection fraction, Sadhbhai? Was it the same before bypass surgery?
Around 40. Or around 40%.
So now it is coming down.
Yes.
So whether it is due to ischemia or due to related to conduction defects, difficult to assess. Yeah.
Because as this patient present also with vomiting and syncope.
What Rofik sir was telling, that is related
Yes,
to
history.
Brady and prolonged
Assistole.
But important issue is the coronary, to check the coronary status before putting any device, especially CRT.
Now, when the patient is not in acute coronary
less
syndrome,
than 1 year.
Yes.
You remember, it is less than 1 year.
It's okay, sir. Even then, I think.
Probably we did not do it. Probably.
So, Rofik sir, what should be our plan regarding coronary revascularization or check the coronary angiogram in such type of patient with low ejection fraction, triple vessel disease, no angina, perfusion defect is not there?
Yeah. So, I mean, what we do, we always look for the coronary. I mean, we always check the coronaries. There's no question about it. For two reasons. First, I want to know the status of the patient. Second, how much risk am I taking during the BIV implantation?
Yes.
Because that's what we always check the coronaries. And if angioplasty needs to be done, we have it done the day before, and we do the device next day or day after. So that's the routine protocol. I have one suggestion. Because the volume of BIV ICD in Bangladesh is not high. The BIHRS should think of doing quarterly just CRT session, so that each institute will present their cases, not only difficult cases, just cases, that this is what I'm doing, this is what we did. And I think then we can pull our experience together, and that will help everybody. Please think about it. Doing a quarterly session of CRT presentation from all the institutes. You can present 4 or 5 cases and go over the thing. And the way it should be selected, some simple case, some difficult case, not only difficult cases. I think it's also good to know how simple things go.
Yes,
thank you.
Yes, sir.
স্যার আপনাকে একটা রিকোয়েস্ট স্যার, রফিক স্যারকে একটা রিকোয়েস্ট স্যার, আমাদের জার্নালটা আমরা ডিসেম্বরে পাবলিশ করতে যাচ্ছি স্যার, ওইখানে আপনি একটা লেটার, আমাদের অ্যাপ্রিসিয়েশন অফ লেটার অফ অ্যাপ্রিসিয়েশন এন্ড ইফ পসিবল এ রিভিউ আর্টিকেল, প্লিজ সেন্ড ইট টু আস।
Sure, I'll do that. Thank you.
ওকে স্যার। আর 2 নম্বর স্যার আমি বলতে চাই যে এনি CRT-D implantation we do the angiogram first before the procedure, just on the table. If there is much difficulty, I just
we don't do 2 procedures on the same day. It's too much for the patient. Also the dye load. So if we do angiogram intervention, of course intervention you do CRT, but we try to avoid same day procedure because it's stressful for the patients.
Tushar, please say something.
Sir, assalamu alaikum. Good morning.
Sir.
I think, sir, today we had 4 interesting and wonderful cases, and we all have experienced different things today. And again, before any, I want something from Rofik Ahmed sir regarding the first case. I think the ECG that was discussed, the read ECG, still a bit of a confusing thing in the first instance. Rofik Ahmed sir.
I mean, the patient at the time of that thing was not in complete heart block. I'm still curious about the first QRS complex. And I have to sit down and look at how did the first narrow QRS start. That is the interesting part. The rest of it is simple atrial pacing going to with long PR conducting to the ventricle.
Yes, that first bit is very is not falling into any defined category, sir.
Well, you have to look at the circuit. You have to draw a picture. I need to sit down and can come up with a good story. Thank you.
Yes, sir. That's a very interesting thing.
We can see a very senior professor with us, Professor Shadil Banerjee. Sir, can you please unmute and say something?
Thank you, everyone. My dear friend, chairperson, and the most legend person in this field, Professor Rofik Ahmed, and all the stars in the field of electrophysiology. I must give you salute. Really, I am here to learn something. I am not expert of this subject, but I had a very good intention to join this program for a long time. When I have heard that this program is going to happen on 27th, today there is also a program in the my starting day of the ESC. Still then, I will remain in the program so far, so long I can remain here. Only to learn from you. And I must express thanks and gratitude to everybody who has presented their cases until now, who has expressed their or shared their knowledge regarding many things. And I express my heartiest gratitude to everyone, particularly the leaders of the Bangladesh Heart Rhythm Society for arranging such a nice symposium. Thank you, everyone.
Thank you.